I think there is good evidence, and based on your responses, to say some sort of imaging is important to select patients appropriately prior to embarking on radium-223 treatment.
You want to have a CT scan to make sure that a patient has no visceral metastases or only low-volume lymph node metastases. We had a meeting, I think it was last year in Oslo, with European experts and experts from North America to discuss how do we as experts recommend to do staging and monitoring in men on MCRPC. For baseline, and we will discuss that in the second talk as well, the recommendation was to do ALP, PSA, LDH, and imaging with a bone scan, a CT scan at 3 months. We didn't think a bone scan was necessary. I think the disease is mostly stable on bone, or it's at 3 months it can be a flare, which you need to follow up with a second bone scan anyway. So I think the bone scan information is less relevant here. ALP is usually falling, but a CT scan to rule out visceral progression should be considered, especially in patients that have a rapidly rising PSA, maybe an increase in LDH, or that are clinically deteriorating. After 6 months at completion of radium, we discussed the option of having a bone scan and a CT scan again, just to have what Val mentioned and Stefano put in a slide, at some point best response to treatment before we go on maybe to follow up or a next treatment, and then follow up as clinically indicated.
I don't think there is an optimal imaging technique to do in between times or during treatment. I really would try very hard not to image a patient during radium therapy, because it might lead me to make the wrong decision and to stop treatment early, treatment that would otherwise have benefited the patient in terms of the skeletal disease control. An interim scan undertaken without having your wits about you might lead you to misinterpret the results. I'm not deliberately trying to dodge your question, but I just really wouldn't do it unless there was a really obvious clinical reason. If you're looking at the patient in front of you who's clearly losing ground and going downhill, who has new symptoms, particularly if those are skeletal, whose PSA doubling time is very short and is just, the trajectory is steadily uphill, those would be sound reasons to say there's something else going on, I need to know what it is because it might be appropriate to change track. But I think it is a mistake to undertake imaging that could lead you into making a decision that might disadvantage the patient. There should be a specific trigger to justify imaging on treatment. That trigger might be significant biochemical progression, clinical deterioration, or an other clinical factor that was unsuspected previously. So the flare phenomenon, if you're not familiar with it, means a fairly brisk osteoblastic response in response to treatment, which on a bone scan might look like an increased intensity of uptake at an individual or many sites. And it shouldn't be misinterpreted as disease progression. It's a physiological healing response in the bone reflecting changes in bone mineral metabolism. And so we are very aware of the risk of misinterpreting early bone scans because of the flare phenomenon. So this is one patient treated with radium-223, and you will notice that following the first cycle of radium-223, there was a very brisk increase in PSA, which subsequently then declined. And that was accompanied by a really dramatic pain flare. The patient was confined to bed for about 10 days. The patient subsequently did very well and indeed had a complete pain response following the second treatment cycle. And that was accompanied by a fall in PSA. And you'll notice that the alkaline phosphatase was actually quite helpful all the way through in this patient, that the alkaline phosphatase seemed to indicate a favourable response from day one. On your right are the relevant images from this patient. So these are taken directly from the paper. The first one is baseline. Second is on ADT. Third one is sipuleucel T. D is following docetaxel. E is following enzalutamide, and it's at E that the patient is then offered radium-223. And F shows us the response to radium-223 with pretty much a complete metabolic treatment response as assessed by the bone scan.